Welcome to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of February 9th, 2026. As health professionals rooted in East Oakland facing some of the widest health disparities in the nation, we're here to bring you timely public health information relevant to us all. This week, continuing our Black History Month briefing series, we're focusing on HIV/AIDS in the Black community, following Black HIV/AIDS Awareness Day on Saturday, February 7th. We'll also close with another Black medical professional feature. Beginning today with the weekly percent positivity chart, which shows the proportion of clinical tests coming back positive for each respiratory virus. Not much has changed here. Flu continues to account for the largest share of detections, though its share appears to be leveling off. Moving to epidemic trends. As a reminder, this forecast is primarily based on emergency department visits, which provides a snapshot of community spread. Looking at flu activity, many states are seeing stable trends. Across much of the East Coast, cases are decreasing, while a smaller number of states are experiencing increases. Turning to COVID-19 trends, activity remains stable in many states, with some areas seeing gradual increases or gradual declines. And while these national trends give us a helpful bird's eye view, the reality of respiratory illness can look very different depending on exactly where you are. If you are interested in knowing what's going on in your specific area, I always recommend looking at wastewater data. Nationally, our surveillance has come a long way. The CDC's National Wastewater Surveillance System now coordinates data from over 1,600 sites, covering about half of the U.S. population. But that coverage is quite uneven. While participation is dense in parts of the Northeast and the West Coast, many other regions remain blind spots in our national map. For a user-friendly look, I still recommend Wastewater Scan. They monitor over 200 sites across 40 states and offer a comprehensive menu of pathogens tracking everything from COVID and flu to norovirus and even hepatitis A. Here in Alameda County, we are fortunate to have a local dashboard that tracks a wide range of threats in real time, including SARS-CoV-2, flu, RSV, Mpox, and even measles. It is worth noting, though, that while we have great coverage in several parts of the county, data for the city of Oakland specifically is not currently viewable on any of these dashboards. So we have to look to surrounding areas as our best early warning for what is likely circulating in the area. I've linked these different resources in the post. And remember, these are tools that we really did not have at our disposal pre-pandemic. So this is an important type of infrastructure that I am glad to see has remained and even improved. It gives us a layer of preparedness we simply did not have 5 years ago. Now, looking at hospitalizations, flu-related admissions appear to continue to decrease, while RSV and COVID hospitalizations remain relatively low and stable. And we look around the same time last year, so looking over to the left of this graph, we see that at least so far, we have fewer hospitalizations for the month of January 2026 than we did in January 2025. And this data is made up of about 90% of the hospitals that are reporting in. So we believe this is generally data we can rely on. Finally, to flu view, influenza can be severe and in some cases deadly. Nationwide, so far this season, there have been approximately 12,000 flu-related deaths, including 60 pediatric deaths, 8 of which occurred last week. It is important to remember that these numbers reflect reported cases and the true burden is likely even higher. As we move into our deep dive today on HIV, I want to introduce a new recurring segment we are calling Behind the Data. As we often do, our goal here is to pull back the curtain on the language of public health so we can all engage with the information. Today, we're looking at 2 fundamental concepts, incidence versus prevalence. These terms are not just for infectious disease. They apply to everything that we treat at Roots, from hypertension to diabetes to HIV. Incidence is the number of new cases that occur in a specific period, usually we refer to it per year or by year. So you can think of this as the faucet. It tells us how many people are entering a specific health category right now. For example, when we look at HIV, the incidence in the United States in 2022 was about 31,800. So that means 31,800 new cases in that year, 2022. When we are able to turn down the faucet through prevention, we are reducing the incidence. Prevalence, on the other hand, is the total number of people living with that condition at any given time. So you can think of this as the pool. It includes everyone, those who are just diagnosed, as well as those who've been managing their health for decades. In the United States, about 1.2 million people are living with HIV. And here's why looking behind the data is so important. Usually in public health, we want to see numbers go down, but with prevalence, it's different. In the early days of HIV, for example, prevalence was actually lower because people were not surviving. So today, because we have effective treatment, people are living long, full lives. So while we do want incidence to be as low as possible, the number of new cases we want to be as low as possible, a stable or even a high prevalence is actually a testament to the success of our care and the resilience of our community. And finally, we have to distinguish both of these from diagnoses. A diagnosis is just the moment that the system so-called sees the person. Someone might be a part of the incidence, the new cases this year, but if they don't have access to care, they might not get a diagnosis for some time. So our goal is to turn the faucet down or reduce the incidence while ensuring that everyone already in the pool or the prevalence has the support that they need to live a long, healthy life. Understanding the difference helps us see past headlines to where we are truly making progress. Today, as we recognize Black HIV/AIDS Awareness Day, we are taking time not just to raise awareness, but to build understanding. HIV and AIDS are often discussed in headlines and statistics, but behind those numbers are real people, families, and communities who deserve clear information and equitable care. By grounding ourselves in the facts, what HIV is, how it's treated, and who is most impacted, we can better understand where inequities arise and what it will take to close them. To begin, we're joined by Camilla Felix, Clinical Program Coordinator here at Roots Community Health.
Thank you, Dr. Noha, for having me on the People's Health Briefing this week in honor of National Black HIV/AIDS Awareness Day. My name is Camilla, and I am the HIV Clinical Programs Coordinator. Today, I will be defining HIV as a chronic and manageable condition, exploring current realities of HIV in Black communities, and highlighting prevention strategies and the importance of culture-responsive care and outreach. National Black HIV/AIDS Awareness Day is dedicated to raising awareness about the disproportionate impact of HIV on Black communities in the United States. This day was first observed in 1999 and has since been key in highlighting the importance of community involvement and improved access to HIV education, prevention, testing, and treatment services. Human immunodeficiency virus, also known as HIV, is a virus that attacks the immune system, specifically the T cells, which helps the body fight infections. Here we have an image that shows how HIV attacks our T cells. So here we have HIV and unhealthy T cell. When HIV attacks the T cell, it's able to enter the cell and create copies of itself inside the host. Once copies are created, it causes the T cell to be destroyed, and then HIV is released into our immune system, where more copies are allowed to be created. If HIV is not treated, it can weaken the immune system over time and progress to acquired immunodeficiency syndrome, also known as AIDS. This is the most advanced stage of HIV. But how is HIV transmitted? So HIV is transmitted through certain body fluids such as blood, precum, semen, rectal fluids, vaginal fluids, and from mother to child through breast milk. With early diagnosis and consistent treatment, people living with HIV can live long, healthy lives with a near normal life expectancy. Effective treatment exists in the form of antiretroviral therapy, which suppresses the virus to very low levels. Once someone's viral load reaches low levels, it essentially means that the virus is undetectable and the individual cannot sexually transmit HIV to others. Today, HIV is treated much like other chronic conditions, such as high blood pressure or diabetes. where regular medical care and medication allow people to stay healthy and prevent complications. But even with effective treatment, Black communities continue to face higher rates of new infections and unique barriers to accessing care, both nationally and here in Alameda County. Here we have a pie chart that represents the total population of people within the United States, where each slice represents a different racial group. Highlighted as a blue slice, we see that the Black community makes up 12% of the total population. Despite being 12% of the population, 38% of new HIV diagnoses in the United States were Black people. That's 14,749 cases out of the 39,182 total new cases of HIV. Looking at this next figure, we have a pie chart that represents the total population of women diagnosed with HIV in the United States. Highlighted in orange, we see that despite representing just 12.8% of the female population in the United States, Black women accounted for 49.3% of new HIV diagnoses among all women in 2023. And in here, we see that Black men were diagnosed with HIV at 2.95 times the rate of all U.S. males in 2023 as well. Switching to our county statistics, we can see that in Alameda County, Black residents experienced about 38 new HIV diagnoses per 100,000 people, which is the highest rate in the county. This rate is more than 5 times higher than that of the white residents and over 10 times higher than Asian and Pacific Islander residents, showing the disproportionate impact of HIV on the Black community. While discussions about HIV often focus on individual behavior, the reality is that broader issues like access to healthcare, testing, and prevention services play a major role in risk. That's why effective HIV prevention requires looking not at just personal choices, but also at the resources and systems that make care accessible. Some of the main ways to prevent HIV include regular HIV and STI testing to know your status, using condoms consistently and correctly, never sharing needles, syringes, or other drug injection equipment, and talking with the healthcare provider about preventative medications such as PrEP and PEP. PrEP is a daily medication that significantly reduces the risk of getting HIV for people who are HIV negative. PEP is an emergency medication that can be taken after potential exposure to HIV, ideally within 72 hours. For people who test positive for HIV, starting treatment quickly is key. Effective treatment keeps people healthy, and when the virus is suppressed, prevents HIV from being transmitted to others. At Roots, we are committed to creating a safe and welcoming environment for everyone. We know that care must be culturally responsive and community-driven, which is reflected in the services we provide. This includes providing services directly to our surrounding communities through our 40 by 40 outreach health screening initiative, where our clinical programs teams provide free incentivized HIV and hepatitis C screenings at community events, local churches, and other Oakland-based community organizations. For updates on when and where Roots will be offering community health screenings, please follow us on Instagram at Roots Empowers. We also have Welcome Wednesday, which is a weekly event held at our location on 99th and International, where all are welcome to receive navigation services, walk-in medical and behavioral health services, as well as free groceries and a hot meal. We also have a street team that's dedicated to outreach within our unhoused population. They go out and bring medical care to the unhoused population in our encampments. And then we have the Young People's Wellness Center, which offers free drop-in appointments on Wednesdays and Thursdays for services shown on the flyer here. And these are intended for individuals aged 13 to 24. I'd like to say thank you again to Dr. Noha for allowing me to honor National Black HIV/AIDS Awareness Day on the People's Health Briefing today. And I hope to see some new faces at our community health screening events and at Welcome Wednesday.
Thank you, Camilla, for that piece on Thank you, Camilla, for that piece on Black HIV/AIDS Awareness Day. Now that Camilla has outlined what HIV is, how it can be managed, and how Black communities are more likely to be affected, we have to talk about how access to treatment does not automatically mean access to equitable care. To fully understand Black HIV outcomes, we have to look at how Black patients are treated once they seek help. Black patients are simply not treated the same in healthcare settings in general, and that difference can be life-altering or even life-ending. This is especially true for Black people living with HIV. Let's start with what this looks like in real life. Research consistently shows that Black patients are less likely to have their pain taken seriously. Black patients are more likely to have their symptoms minimized. their pain undertreated, or their concerns dismissed altogether. This is not because Black patients experience less pain, but because longstanding false beliefs about Black bodies still influence medical decision-making today. Now imagine how dangerous that becomes when someone is living with HIV. HIV care requires trust. It requires regular engagement with the healthcare system, careful monitoring of symptoms, and timely treatment. If a patient's pain, fatigue, or complications are brushed aside, conditions can worsen before they are addressed, sometimes catastrophically. In emergency departments specifically, Black patients are less likely to be admitted than white patients, even when presenting with similar symptoms. At the same time, Black patients face higher odds of dying in the emergency department or hospital. That combination tells us something critical. This is not about individual choices or biology. It is about how the system responds. A major driver of these disparities is implicit bias. Implicit bias refers to unconscious attitudes or stereotypes that affect how clinicians interpret symptoms, assess risk, make treatment decisions. Even well-intentioned providers can unknowingly underestimate Black patients' pain, assume noncompliance, or delay aggressive treatment. For Black patients with HIV, implicit bias can affect how quickly symptoms are investigated, whether pain is adequately treated, how seriously medication side effects are taken, and whether patients feel respected enough to stay engaged in care. But bias does not exist in isolation. Structural racism shapes the conditions in which many Black patients live long before they ever enter into a medical establishment. Economic disparities disproportionately place Black communities in environments with limited access to healthy food, safe housing, quality health care, and clean air. These are some of the social determinants or social drivers of health, and they compound over time, increasing vulnerability to illness and complicating disease management. HIV does not exist outside of these realities. Although HIV treatment has advanced dramatically, Black communities have benefited less from innovations. Preventative tools like PrEP, or pre-exposure prophylaxis, which can nearly eliminate the risk of acquiring HIV, are vastly underutilized among Black adults compared to white adults, despite similar or greater need. The gap reflects barriers like cost, access, medical mistrust, and biased assumptions about who is appropriate for preventive care. The result is a pattern we see across nearly every area of medicine: worse care, worse outcomes, and higher risk for Black patients, even when controlling for income, insurance, and disease severity. This is not accidental. Structural racism is a system that assigns value and opportunity based on race. It privileges some groups while disadvantaging others through policy decisions, environmental exposures, and healthcare practices. It operates quietly, but its effects are deadly. For Black people living with HIV, this can mean delayed diagnoses, inadequate pain management, reduced access to cutting-edge treatments, and higher rates of complication, despite HIV being highly manageable when care is equitable. So when we talk about improving HIV outcomes, we cannot focus only on medications or individual behavior. We must also address how bias, inequitable systems, and social conditions shape care itself. It's about ensuring that Black patients, especially those living with HIV, are believed, respected, treated aggressively when needed, and given the same chance at health and longevity as everyone else. This is not just about good medicine. This is an ethical obligation. Even with medical advances that make HIV a manageable condition, stigma remains one of the biggest barriers to prevention, testing, care, and well-being in the Black community. Stigma around HIV includes negative attitudes, judgments, and beliefs about people living with the virus. It can be both perceived, the fear of being judged or rejected, and enacted, actual experiences of discrimination from others, including family, friends, community members, and even healthcare providers. This stigma doesn't just hurt feelings. It can keep people from getting tested, seeking treatment, or disclosing their status to loved ones and partners. For many Black individuals living with HIV, stigma is compounded by racial discrimination, cultural norms around sexuality, and historic mistrust of medical institutions. These intersecting pressures can silence important conversations about HIV and reinforce harmful misconceptions about who gets HIV and why. Research also shows how social support, especially from friends, can buffer the negative effects of stigma. Black people living with HIV who perceive strong support from their social networks often report less internalized stigma and better emotional well-being. That support can make it easier to navigate disclosure, engage consistently in care, and maintain treatment adherence. Despite these challenges, Black people living with HIV are not just surviving, they are thriving, building community, speaking out, and reshaping the narrative. Many share their stories, educate others, and create spaces where HIV status isn't shamed, but it is supported. Addressing stigma is not just a matter of being nice or of kindness, it is a public health imperative. Reducing stigma improves testing rates, strengthens care engagement, and ultimately helps close the gap in HIV outcomes for Black communities. Now I want to turn to one of the most exciting recent advances in HIV medicine, a drug called Lenacapavir, brand name Sunlenca. This is a long-acting antiretroviral that targets the HIV capsid, the virus's protective shell. By disrupting that shell, it stops the virus from replicating, and it even works against strains that have become resistant to older drugs. As exciting as this is, we need to have some real talk about where this drug stands today. While Sunlenca is already FDA approved for treating people with multi-drug resistant HIV, we are currently in a frustrating limbo regarding PrEP, or pre-exposure prophylaxis, the kind of prevention that can turn down that faucet we talked about earlier. In clinical trials, Lenacapavir was a miracle for prevention. A shot given just twice a year was virtually 100% effective in stopping HIV transmission. This removes the burden of daily pills. It overcomes the pill fatigue that leads to missed doses, and it bypasses the stigma of having a bottle of HIV meds in the medicine cabinet. The catch, as of right now, it is not yet widely covered by insurance for PrEP. We are waiting on the final FDA label expansion for prevention, and more importantly, for payers like Medi-Cal and private insurers to add it to their formularies for PrEP. Without that coverage, the cost is astronomical, upwards of $40,000 a year. Unfortunately, we see this all the time. A breakthrough happens in a lab, but it doesn't reach the people because the system is too slow, is too expensive, or too indifferent to the needs of those most impacted. We cannot call something a medical advancement if the people who need it most cannot get it. The World Health Organization has already recommended Lenacapavir, specifically noted its potential to reach communities that the traditional healthcare system has historically left behind. But unfortunately, as we discussed last week, we are in a moment where the United States has pulled out of the World Health Organization. So while the rest of the world is looking towards global cooperation to end the epidemic, the US is stepping back from the table, distancing ourselves from the organization that is setting the global standard for health equity. So while we celebrate the science of Lenacapavir, we have to keep fighting the advocacy battle. We need to demand that the gold standard of prevention isn't just for those with the best insurance, but is accessible to every person walking through our doors, and frankly, to everyone across the globe who needs it. And now I'm glad to turn to our Black History medical professional. As part of the spotlight, today we honor Nurse Ophelia Long. Nurse Ophelia Long was a visionary nurse, leader, educator, and advocate whose life's work reshaped healthcare access for Black and underserved communities. Born in Birmingham, Alabama in 1940, she dedicated her life to advancing health equity and to challenging systems that were never designed with Black communities in mind. She believed deeply that healthcare should live within the community, not above it, and that dignity, safety, and access were non-negotiable. Her career in nursing spanned decades, including 27 years at Kaiser Permanente. She began as an ICU nurse and eventually rose into administrative leadership. But her approach never changed. Her leadership was always rooted in people. While leading at a Kaiser facility in Watts, California, she noticed that nurses felt unsafe leaving work at night. Instead of accepting that as normal or unavoidable, she asked what the hospital could do differently. She organized community patrols and helped establish child guidance clinics, family support centers, transportation services, and anti-graffiti programs. She brought together residents, staff, and local leaders, and in doing so, improved both safety and patient access. The results surprised many. The hospital did not lose staff, it gained trust. She carried that same philosophy to Oakland's Highland Hospital during a period of crisis. The hospital had lost its accreditation and morale was low. Nurse Ophelia responded by listening first. She engaged hospital workers, community members, Black churches, inviting them into the process of rebuilding. Within 6 months, Highland Hospital was reaccredited. Staff painted the walls themselves. Ministers volunteered. Counseling services were added. Healing became a collective effort, not just a clinical one. The importance of Nurse Ophelia's work cannot be overstated. At a time when healthcare systems often treated community concerns as peripheral or inconvenient, she made them central. She showed that safety, trust, and access are not separate from quality care, but foundational to it. Her work demonstrated that hospitals do not function in isolation. They succeed when they are accountable to the communities they serve. Long before community-based care became a widely used phrase, Nurse Ophelia was practicing it, proving that equity-driven leadership was not only morally necessary, but operationally effective. Nurse Ophelia's leadership extended far beyond local institutions. She became the first registered nurse to serve as vice president of Meharry Medical College, a historically Black medical institution. From 1983 to 1987, she served as the fourth national president of the National Black Nurses Association. During her presidency, she helped launch the Journal of the National Black Nurses Association, expanding space for Black-led research, scholarship, and professional voice. She also served as treasurer of the National Black Nurses Foundation and chaired the Black Congress on Health, Law, and Economics, helping shape national conversations on workforce diversity, cardiovascular health, violence prevention, and community wellness. Nurse Ophelia also has a special and deeply personal connection to Roots Community Health. In 2008, she co-founded Roots Community Health alongside me. What began as a two-person volunteer mobile operation delivering care directly to Oakland's most marginalized residents grew from her unwavering belief that healthcare must meet people where they are. Nurse Ophelia believed fiercely in the vision of Roots. She was a mentor to me, a mentor to generations, a tireless advocate for the people, and a leader whose influence is woven into the fabric of this organization. Her voice reached the national stage as well. In 1992, Nurse Ophelia testified before Congress during a joint economic committee hearing on health insurance reform, rising healthcare costs, and injustices within the healthcare system. Her words captured the clarity and conviction that defined her life. She said,
"One of my favorite Psalms reads, 'The just man murmurs words of wisdom.' Whenever I hear that psalm, I remember my father and all he taught me. One of the greatest lessons learned was you can tolerate insults, you can tolerate pain, you can tolerate hunger, you can tolerate thirst, but you cannot tolerate injustice. For if you tolerate injustice, you're no longer human." Those words have given me strength when I needed tolerance. Those words have given me power when I confront injustice. I'm a woman who is Black. I know injustice. I have lived through the civil rights era. I know injustice. I'm a woman in a position of authority who has witnessed less.
Nurse Ophelia Long passed away in Oakland, California on August 16, 2020. But her legacy endures through Roots Community Health, through the nurses and leaders she mentored, and through every effort to bring care closer to the people. We honor Nurse Ophelia by continuing the work she began, uplifting communities impacted by systemic inequities through navigation, empowerment, and care. Thank you so much for joining us for this week's episode of People's Health Briefing. As we close today's briefing, we have covered what HIV and AIDS are, how far treatment has come, and why, despite these advances, Black communities continue to be disproportionately affected. These disparities are not about biology, but about inequities in care, bias, stigma, and the lasting impact of structural racism. We've talked about unequal treatment in healthcare settings and the role stigma plays in delaying care and isolating people with HIV. At the same time, we've recognized the strength and resilience within Black communities that continue to push for better outcomes. This is where the legacy of Nurse Ophelia Long comes in. Her work reminds us that healthcare is about more than treatment. It's about dignity, trust, and advocacy. Her example challenges us to continue building systems that truly serve the communities most impacted. On Black HIV/AIDS Awareness Day, awareness must lead to action. When Black people living with HIV are believed, respected, and supported, outcomes improve. That is how we honor those impacted today, and that is how we honor the legacy of leaders like Nurse Ophelia Long. This concludes today's People's Health Briefing. Thank you for joining us, and we hope to see you next week, Tuesday at 10 a.m.